Okay, good afternoon, everyone. Welcome to our second presentation in our professional development series focused on the peer specialists and certified recovery peer advocates and how they can help address co-occurring disorders, and how by getting certified or having folks certified in your organization can help not only drive the outcomes you're looking for, but really reach your clients in a different and deeper way and increase the impact that you've had and that you would like to see. Today we have two incredible presenters. If you joined us last week, you have already had the pleasure and excitement of not only learning more about this field, but the many different ways that you can utilize different tools and resources and experiences to grow this field. So thank you, Dr. Jonathan Edwards and Chacku Mathai, for your time and your expertise. We would not be able to have this event or this series without the wonderful support from the Opioid Response Network. Thank you, Katie. And also from our partners at the Mental Health Empowerment Project, and also for our expanded audience. We would not be able to have that without the support and sponsorship from the Hudson Mohawk Adult Education Center. So if you wouldn't mind just introducing yourselves in the chat, putting your name and your title and your organization and any contact info if you're willing to share. You'll also notice at the top of the chat, I put some resources on getting certified and also on ongoing professional development. If there are upcoming professional development opportunities or events that you would like us to share on our calendars and on our social media websites, please also send me those. My information is in the chat as well. And for now, I'm going to turn it over to Katie.
Thanks, Carrie. Hi, everyone. So before we get started, I'm just going to speak a little bit about the Opioid Response Network. My name is Katie Cunningham, and I'm a technology transfer specialist with the Opioid Response Network, or ORN, which is a SAMHSA-funded organization that provides free training and technical assistance to communities and organizations related to opioid and stimulant drug use, as well as substance use overall. And we provide training and technical assistance in the areas of prevention, treatment, and recovery. So I'm part of the team that handles technical assistant requests for the New York and New Jersey area, but the ORN has a large network of subject matter experts available across all 50 states and US territories who can provide training and technical assistance. And this can look like educational resources, training such as the one you're about to get today, or guidance on implementation of evidence-based practices. And it's free of charge with the goal of strengthening local organizations and community responses to the overdose epidemic. We handle requests from organizations of different backgrounds, from hospitals to local nonprofits, from healthcare providers to peer advocates. And submitting a request to the ORN is a very quick and easy process. Our website is opioidresponsenetwork.org. I will put that in the chat. And all you have to do is click the large submit button in the upper right-hand corner. A request takes about 5 or 10 minutes to submit. And then within one business day, you'll hear back from a TTS, either me, if you're in New York and New Jersey, or someone else around the country. And if you'd like more information or have questions regarding a request you're interested in submitting, just email me. I'll put my email in the chat and the website as well, and you can reach out that way. And also for access to CE credits for this training, those certificate links will be sent out with the resources email that Carrie will send out next week. And that'll also include the slides and any associated materials or resources that the speakers want to include. So with that, I will turn it over to our trainers for today.
Thanks, Katie. All right, I'm going to maybe go straight to, maybe we'll go back to this slide, Jonathan, and kick it over to you. Hope you're on mute. Yeah.
Good afternoon again, everyone. Jonathan Edwards here with Chacku Mathai. We're really happy to have this opportunity again to speak with you all about integrating peer support for people with co-occurring disorders in multiple settings. We were here 2 weeks ago, and so probably some of you were with us at that time. What we're going to do in several slides is say a little bit more about ourselves, and if we can go back to the housekeeping slide now, we just wanted to encourage everyone here to take advantage of the various Zoom platform features, the hand-raising feature, the chat feature, which you're already familiar with, and also the virtual reactions, if you have access to those. And of course, we will allot some time to actually hear your voices if you're comfortable sharing in that way. We also want to encourage you at the end, last time I think we moved a little swiftly, that there's an evaluation survey at the end, and it's really important that we get feedback, because even though Carrie gave us this wonderful introduction, one of the things that we espouse and embrace in our recovery journey is always looking to engage people more heartily. So if there's anything that you feel we need to know about how we conducted this or the content, we really want to hear from you. It's not just a popularity contest, but it's to really help us to help you more. And as they say with housekeeping, you know where the bathrooms are, and hopefully you have your lunch in front of you. And I think for housekeeping, that's it. We could move ahead. So Chacku, always glad to hear about you. Yes.
Hi, everyone. So yeah, I am so excited to be part of this project and to be part of the Opioid Response Network team. And it's an incredible national technical assistance project, very impressive, and an honor to really be a part of and to speak here with you, Jonathan, Carrie, and everyone, Katie and Emily, and everyone at MAHAP has brought together, a lot of people for these presentations. So it's a chance for us to learn, together. And so I'm although my bio and Jonathan's bio is up here, I want you to know that a lot of the experience that I think both of us are collectively sharing with you is the collective wisdom of our community, of our movement, of the work that's been done before us and with us, and since our work has shown up in this time in the world of peer support. So I myself am a person in recovery. I'm a person who's been through a number of experiences. I started some of the first peer support meetings in my community in Rochester, New York. I live upstate. Now I was in New York City as well when we immigrated to the country. So, a lot of the 35 years that I would say, every single year of my efforts have been centered in the rights and experiences of those of us with mental health and substance use challenges. And so I think the opportunity to speak to all of those areas of challenge and opportunities, it's just a real honor. I'm just so grateful that we get to do this now. So thank you. Jonathan, I'll turn it over to you.
Yeah, thank you, Chacku. And I can't say enough about the things that Chacku does. I mean, I'm supposed to be introducing myself, but I just want to say that I'm really proud to work alongside my fellow peer, and it's really a great honor, and I consider Chacku somewhat of a mentor. And so I've been in long-term recovery in one form or another for the past 30 years, but every day is a new beginning. I just want to say that ever since we've been live for these last few minutes, my headache is dissipating. I'm feeling a lot calmer, and I'm feeling more like I belong, and I'm really happy about that. And Carrie has a really reassuring smile, so I'm grateful for that too. And so I do a lot of work in peer support, workforce development. I also work for the New York City Department of Health and Mental Hygiene. I don't like the name, but that's where I work. I also teach at Columbia University School of Social Work, and I'm really happy to have an opportunity to infuse a more recovery-oriented lens, strengths-based perspective, trauma-informed care, and also the importance of intersectionality and cultural awareness and sensitivity into curriculum. So very happy to do a lot of this work. And Also, I did dissertation research on peer support worker job satisfaction, and I'm trying to publish on that right now. So I could go on and on and on. But the last thing I'll say is, you know, the lived experience is basically what got me here now. And when I heard Chacku talking about his 35 years, I thought to myself, yeah, you know, I had all this lived experience that I learned to reframe, and then I went back to school. So, you know, all that to say is that my foundation is recovery oriented even before I knew it was recovery oriented. And I'm glad to sort of have both of those lenses. And so with that, we can move on to the next slide. I'm really looking forward to these next 2 slides.
Thank you, Jonathan. So yeah, before we begin, we really want to start with some important acknowledgements. And so as a land acknowledgement, we share that we are each likely participating on the ceded and unceded land of an Indigenous people. So for me, where I work is the Lenape homeland, or Manhattan, and where I live in Rochester, New York, upstate, is the traditional territory of the Haudenosaunee. And by honoring the sovereignty of the 6 nations here, the Mohawk, Cayuga, Onondaga, Oneida, Seneca, and Tuscarora. So I ask you to join me from wherever you are in acknowledging all the Indigenous people and all ancestral and unceded lands of their people, their elders, both past and present, as well as future generations. Most of the institutions for which we work must also acknowledge that they were founded upon the exclusions and erasures of many Indigenous people. This acknowledgement is a small way to demonstrate a commitment to begin the process of working to dismantle the ongoing legacies of settler colonialism. And another important acknowledgement is labor acknowledgement. And we must acknowledge that much of what we know of this country today, including its culture, economic growth, and development throughout history and across time, has been made possible by the labor of enslaved Africans and their descendants who suffered the horror of transatlantic trafficking of their people, chattel slavery, and Jim Crow. We are indebted to their labor and their sacrifice, and we must acknowledge the tremors of violence throughout the generations and the resulting impact that can be felt and witnessed today. And so this is an acknowledgement that carries into the work of our project in this presentation. There is no way to separate the impact of those erasures and of the tremors of violence that we've experienced that carry into the very history and origins of our field and of our work. So addressing that is part of the commitment that we've made here. So I'm going to stop the share here and turn it over to Jonathan for a discussion on our objectives.
Thanks again, Chacku. So there are 47 people here. That's a really good number. And we're excited to hear from you, as well as to share with you our experience and some of the content that we have brought today. So we'd like to kind of take this opportunity to ask if you would share in the chat what your expectations are, or one expectation that you have of today's, and I'll call it a session or dialogue, because sometimes training sounds a little unidirectional and not interactive. So what is one expectation that you have, either that you'll receive or that you'll bring into the room? So who gets the door prize? David, because he was first. And David said, what did David say? David said, well, David, you're introducing yourself. That's the most important thing, is that you're here. What is it that you and others expect? What you'd like to walk away with? If you'd like to unmute David, please go ahead. So Rebecca says, I want to walk away with more tools to assist folks. Wow. That's great. That's great. So we're going to share with you some of how we do that. And Kevser says, to learn and expand my skill set. Okay. I'm always looking to do that too. Victoria says, I would like to know if peers are implemented in EDs. Okay, you're in the right place because we're going to talk a lot about implementation in various settings. Hands Across Long Island is here. Hey, Stanley, how are you? And yes, Lawrence, please unmute yourself and go right ahead.
Yes, sir, and thank you. Well, first of all, thank you for having me. I appreciate it. I look forward to learning everything I possibly can here. I just recently became certified as a peer supporter. I work for C&G as a veteran outreach specialist. And excuse me. And my work phone is going off. I'm also a disabled veteran. I served the Navy from 2008 to 2012. I want to help. I want to try to help and spread awareness about PTSD. And about how not all veterans are these stressed out people who are living up in the mountains somewhere. And I'm sure that is and there is some degree of truth in that. But we're not all like that. So
Lawrence, thank you so much for the important work that you do, for showing up, for your courage and for your service. And you've just kind of validated why we're here. And thank you for that. So looking forward to hearing more from you. We have Robert, looking to expand my understanding and how to utilize in emergency room settings. Okay. Do we have one or two more?
Yeah,
I guess you're all holding out, huh?
David had raised his hand, I see.
David, go ahead. David, I recognize
I
you.
apologize. Yeah, apologize, Mr. Edwards. I couldn't get my phone to cooperate with me. Yeah, and I really didn't have, you know, I just, I'm looking forward to this being a simple way for me to learn. I'm not a fast learner, so it's good that the way you guys laid it out last time was good, really good actually. And I want to learn and absorb, receive, and take some tools that I could use in my current situation at work, in my position.
Really glad you're back. That's a good sign. All right, so we're going to move along, and there'll be lots of opportunities to, jump in and add to the flow. So if we can go to the next slide. So we have a few learning objectives that we'd like to add to what you've all put in the chat. And so we're really looking to talk about various models of peer support, working with interdisciplinary teams. I know for myself, I directed a peer support program in a hospital for 4 years, and I think I provided supervision for approximately 30 peers at one time, peer supporters working in 5 different service settings. And so they were in the ED, inpatient units, outpatient program, partial hospitalization program, and also a program that was focused on assisting people who were impacted by the earthquake in Haiti. So we're going to talk a lot about that. We're also going to talk about organizational culture change that might result from the inclusion of the lived experience paradigm, but we're also going to talk about organizational culture change that's necessary to happen in order to make that happen in the first place. So we're going to do a little bit of before, we're going to do a little bit during, and we're going to do a little bit after to really talk about the continuity of embedding a more recovery-oriented focus in organizational culture. We're also going to identify some of the essential elements for integrating peer support in hospital systems. And one of those, happens to be making sure that you have all stakeholders on board, particularly human resources, making sure that everyone in the organization really understands what the culture change is about. And then lastly, we're going to describe some of the shifts in secondary and higher educational systems that result from integrating peer support and recovery-centered strategies. And most of you probably know that peer support is a model that's utilized a lot in educational systems. In fact, that was one of the systems in which I sort of learned some of my original knowledge of peer support. And peer support exists in a multitude of other settings. And today we're going to focus on interdisciplinary teams in behavioral health settings. Next slide, please.
All right, so thanks, Jonathan. And so it sounds like we're going to be able to cover the objectives that people have, at least the ones that were disclosed already. So we'll certainly try to make sure that there's information about some of the specifics as you described it. But what we're starting from is this basic frame of why focus on those of us with co-occurring mental health and substance use disorders. Well, the reality that had been ignored for some time, actually, in New York State as well as across the country for decades, even especially as I was showing up in the system, was that people were really getting treated either for a mental health condition or for a substance use disorder. And to actually be one of the people who were struggling with both meant that you were finding yourselves in services that were either addiction only or mental health only, right? So it was literally two different sets of doors, sometimes leaving whole systems, right? And so even our structural kind of framework of governance had shifted. One time it was integrated, then it was separated again. So the reality, though, for the person and the families that were struggling is that the combined impact of having a substance use disorder and a mental health condition resulted in significant functional impairment, disabling experiences. It not only because of the system, but also because of the complexity of our needs. Treatment outcomes weren't as good. There was a higher morbidity and mortality rate. There were higher costs. We were in and out of the system more often. We were in and out of emergency rooms, in and out of crisis, more police involvement, higher risk of homelessness, definitely higher levels of incarceration and mass incarceration and suicide, and of course, overdose rates. So like all of these factors resulted in guidance that, we had in New York, for example, a task force on co-occurring disorders treatment. Back in 2007, there was guidance that came out around really focusing on what we called the quadrant system of really making sure that people were treated for both mental health and substance use at the same time. Now, this was the gold standard of approach, but the regulations and the systems and all the things, including peer support, had still been very siloed. And the only people that were actually working with people actively in an integrated way were people who weren't funded by the services or the system. So the mutual aid programs, the peer support models that were out there that weren't directed by the system to either focus on mental health or substance use were actually the ones that were finding themselves most successful in working with people with co-occurring mental health, substance use, and by the way, physical health conditions as well. So that story continues and goes further, but I'm going to kind of stop with this image and this visual of just who was getting treatment and who wasn't. So again, you can see in either case, whether it was for people with any kind of sign of mental health issues or people who are identified like myself and others with serious mental illness, and that's a category of diagnoses, essentially. There was a good majority of people that were still not getting any treatment. And I think that's the thing that we need to look at here, that there were people who were getting care, and even when they were getting care, they were either getting mental health but no substance use, or substance use but no mental health, or they were not getting treatment at all. All right, so that's a takeaway I want you to consider, and what is the role of peer support in really helping solve that? And then here we're talking about how we really bring peer support into those settings and systems in order to make change. Now, I'm going to bring a major point here forward to just get right to some of the organizational change and culture kind of issues that Jonathan was talking about in the objectives, with a point that says, I think if you're walking away about peer support, one thing to know is that peer support is about social change. Peer support is about social justice. It's not just a service to add to your system. And so when we bring about change in our societies, or when we try to do so, we're treated sometimes first with indifference or with ridicule or with abuse and with oppression. Now, A.T. Ariadne is a Sri Lankan activist that I've often followed around in terms of what he was up to. And he came up with this quote, and finally, the greatest challenge is thrown at us. We are treated with respect. This is the most dangerous stage. And I reflect on this in the context of peer support coming into systems, is that a lot of times, look, some of my first peer support meetings were held, I'm literally in closets, in the closets of a psychiatric center, all right, because that's the only place they could find for us. My very first ones weren't even allowed. I was snuck in by a tech, all right? So the valuing of peer support and whether we were even in the room, I wonder sometimes, what sometimes we might have lost, when we actually were said, oh, here are the keys. We'd like you to be here. Or we'd like to actually be paid for in Medicaid to do this. Or, there's a lot of things that have changed. So what does that respect look like? And what did it look like now that we were no longer in a closet, but now having a peer support meeting in a boardroom, which I remember, by the way, happening as well. And we were given one of the nicest rooms in the hospital as well. So what is that challenge, and why is that a challenge, is the question I'm posing to you. And feel free to throw some answers to that in the chat. What do you think about that? I'm so curious what your reaction to that might be. What is why is that a challenge to be treated with respect? And why is that the most dangerous stage of our process? So I'm not going to wait for your answers. I'm just going to try to also just join you in the conversation and offer one of mine. And that is that we are always at risk of recreating the qualities that outraged us in the first place. And I use the word qualities intentionally because we don't usually start things because we with bad ideas. We think they're qualities, and we start to pour cement into them because they're qualities. And then later on, we might find that they're causing someone harm, or they're not exactly what we wanted, or somebody else is outraged because it affects them in a different way than it affects us. And in peer support, we learn from that. And I'm hoping that as a healthcare system, we learn from that. That's what a learning healthcare system would do. That's what a transforming healthcare system would do, is hear what's not working for people, as opposed to saying, yeah, I just think that's something wrong with you. Just do this more. What we're actually saying is let's hear and center what people are saying and learn from that. So in peer support, the same challenge is true, that we could very much be we could become the same thing that we wanted to change. Another story that kind of tells that point, and this is a story that comes from Michael Quinn Patton. He's a qualitative researcher, and he talked about this in the context of program evaluation. So those of you who are program evaluators, you can think about it from that context, but I also want you to think about it, and you can probably think about it from a personal context as well. But in this case, I want you to think about it from the context of peer support, like the model of peer support. So a traveler comes to a new land and comes across a peacock. And having never seen this kind of bird before, he took it for a genetic freak. He taking pity on the poor bird. He was sure that which would not survive in that form. He trimmed the long, colorful feathers back, cut the beak back, and dyed the bird black. And there now, he said with pride, you look more like a standard guinea hen, which is a bird that he was familiar with, which was a bird that he was comfortable with, which was a bird that he understood. Peer support runs into that challenge quite a bit, right? Where we find ourselves, the peacock in the room, that people are wondering, how can something like this in that form survive in that system? Not only survive, but how could it actually, surviving means trimming our feathers. Surviving means cutting our beak back. Surviving means dyeing our feathers black to look like everything else. But that's not what is intended by a transformative social change model called peer support. We're actually intended to be more disruptive than that. And so I tell the story about this one time I was telling the peacock story in Vancouver, Washington, to a bunch of people out there out west about the SAMHSA core competencies. And again, I've told this peacock story probably for 30 years now. And so I was telling it there, and this man from Alaska said, "Hey, Chacku, we have a story just like that." And I said, "Oh, okay, cool. Stand up and tell it." So he tells this story, and he goes, "Well, a man from a faraway land came and saw our great white bear. And he too had never seen such a great white bear before. He's only seen black bears. So in order to feel more comfortable, he approached the great white bear to dye it black, to be more like the black bear." And then he paused. And there was a lot of kind of uncomfortable laughter for a moment. And he said, "So the bear ate him." And everybody roared. It was just like a huge applause. People were on their feet like, yes. And I was, so what's happening right now? What do people think about this? What are you feeling right now about this? And what people were feeling was that this bear, she honored her integrity, who she was. It wasn't just about eating the man. I mean, I'm sure we were excited about some of the absolute rejection of the idea of being dyed black in that situation, but the real honoring of what we're about. How can we do that, whether we are identifying as the peacock or the bear? And the key is in peer support, guess what? We also look at how we can identify as the traveler. When do we find ourselves, whether it's with the individuals or programs or systems or communities, find ourselves doing the same thing because of our power and privilege? And how do we avoid doing that? And so those were the challenges of our evolution of peer support, and I'm not going to go into all the detail of our whole, history of our movement. That's a whole presentation in and of itself, which I'm happy to do sometime for you. I'll be doing those at different times. But, as I was showing up, peer support had already been emerging in the 70s. I showed up in the 80s, but by the 70s, there were models that were organized, ex-patient, consumer, ex-addict movement was going on back then. We had a lot of different movements that were about rejecting the trauma of the system, rejecting the messages of the system, that there was something wrong with us, for example, and that there was something, and that people needed to be separated or put into warehoused in hospitals or kept in jail. And the civil rights and liberation movement of the 70s led to a lot of acknowledgement by the system. Actually, by the 80s, in 1985, some of the first peer support drop-in centers were actually getting funded by the National Institute of Mental Health, which later became SAMHSA as well. And SAMHSA started funding consumer-run drop-in centers. On Our Own conference, with the first alternatives conference, was in Baltimore, Maryland, hosted by On Our Own, which was one of the first, peer-run organizations in the country. And then, we had this huge amount of systems funding in mental health, specifically around funding peer support models like the Peer Bridger Project, which I was involved in, and peer support models like, that I'll be explaining in a little bit more. And then by 2000, there were more programs happening in addiction recovery community organizations. Peer specialists were getting recognized. CMS put out a letter in 2007 saying we can earn Medicaid revenue by using peer support. That flipped a switch for providers who were Medicaid run providers, and were able to now offer services. I want to acknowledge Larry and the veterans peer support model. There was a man named Mo Armstrong who has been part of leading a vet-to-vet model of peer support for a long time. And that led to the VA really acknowledging the need for veterans-based peer support models, that vet-to-vet. And I've seen some incredible models of peer support by veterans all over the country. Right down, there's a coffee house, for example, in Oklahoma that I got to visit called The Bunker. It was like an amazing place. And again, the common experience there was being a vet and going through mental health and substance use conditions. So in the 21st century, we had an incredible variation of models and prolific kind of effort. Now, again, I'm going to move forward because there were some challenges that people found right from the get around that. Now, one of them was that there were so many different models and so many different places that, getting the money, there were advocates like Howie the Harp that said, look, maybe we shouldn't take the money. We're going to get trimmed back if we take the money. Then there were advocates that said, no, there's no way to make this happen without being part of the system. So Clifford Beers, for example, is one of the advocates that started, some of the first organized efforts around advocacy with the system and started softening some of the messages. So what happens to us from an advocacy perspective, even in peer support, when we're willing to take the money, right? So that's one of the questions that I was bringing forward in this process as well. But there were hiring of peers at every level of services, correctional systems, inpatient. We had peer bridgers coming out of Sing Sing and Rikers. We had inpatient hospitals. We had state hospital run, ambulatory services, mobile crisis, ACT teams, all were bringing peer support in. So the specialty models were incredible. We have, I'm a member of the Hearing Voices Network, for example, which is not funded mutual aid model for those of us who identify as having, whether it's hearing voices or other sensory disruptions or different experiences. There's peer-run alternatives to suicide models that are out there that are also not funded by the system directly. Healing Through Hip Hop is another one. Peer crisis diversion models, warm lines, peer run respite, crisis stabilization. We have the CAHOOTS model out west that was a non-police crisis intervention model with peers and EMTs, being trusted to respond to and only having to call in police only 1% of the time. Peer bridging, which is supporting people to not only get out of the hospital and stay out of the hospital, but what we say is we supported each other to get the hospital out of us. We had adult home peer bridgers. We had homeless shelter bridgers. We had criminal justice setting models that some of you are already involved in. There's a great deal of expertise right in this room, I know, around these various models of wellness, recovery centers, rights protection, and advocacy, which, by the way, whether it's ombudsman or other kinds of rights protection and advocacy peer support, there's been a reduction in. So there was a dramatic increase over time in the types of services, but there was also a similar dramatic decrease in rights protection and advocacy services that were peer run. And that's something to just note and pay attention to, and maybe we ought to do something about. Then there was rehabilitative models, peer supported housing, employment, education, healthcare, emergency rooms. So I'm going to stop there with the peer run specialty items. We have to, because I want you to just identify a few of these. But then from an interdisciplinary perspective, then came the models of working with multiple, seeing peer support in and of itself as a discipline. And so Jonathan and other people's work with the National and International Association of Peer Supporters really helped build what was understood as a discipline that could be utilized within models like On Track New York, which is where I work, for example, with young people going through their earliest experiences of hearing voices or seeing things that other people don't hear, or having beliefs that are disruptive to their school, work, or relationships. There's the core pen medicine model, which is the emergency room. There's living room models, ACT models, as I've mentioned already. So, and then there's more newer models of the certified community behavioral health clinics, which I was a part of helping write the criteria for with SAMHSA, and some of those models allowed for financing that actually paid for peer specialists to be part of the CCBHCs. There's actually money there that could contract with peer-run organizations too. So one of the things we're going to mention here is not just hiring peer specialists or recovery coaches to be part of the system, but also contracting with peer-run organizations like Baltic Street or other recovery community organizations that are all over New York State and all over the country to actually operate the peer-run service and independently supervise the peer-run service in collaboration, which is what the peer bridger model is, for example. So I've said a lot here. I think I need to stop here, right, Jonathan? Is there anything that you wanted to offer? Let me get you in this conversation for a moment.
Well, it's interesting. Well, first of all, when you refer to peer support as a discipline, I remember about 12 years ago when I was going over to take the job at Kings County Hospital, and my supervisor at the time actually said, you know, you need to look, she wasn't a peer, but she said to me, you need to see this as a discipline. You're a discipline director. So she really helped me to empower myself to go into the setting and to not look at just overseeing a service, but changing a culture, you know, and these models, these various service models that Chacku talks about, the good news is that I haven't worked in all of them, but I know about many of them. I'm not attesting to be an expert, but I know about many of them, which means that they're known, you know, and, you know, why should peer support be one-dimensional? You know, nothing else is. There's specialties in social work, there's specialties in psychology, there are specialties in medicine. Are there any in psychiatry? I don't know. There's community psychiatry, but yeah. So we're really layered and multifaceted, and that's the good thing about this presentation is we learn so much about the different layers and the dimensions of peer support. I know there's a slide that was coming up on successful interdisciplinary.
Yeah, I'm gonna be going into that. I just didn't want to be talking so much.
Oh, yeah. Okay.
Weighing
Well,
in
yeah.
first. I'll come back into that and then turn it back.
Yeah.
So I think I wanted to emphasize that Rebecca also is on the group here, and put in the chat that we have, you know, a group of peer-led organizations across New York State that she's a part of organizing through the IPA, which is the Western and Central New York IPA. You can see there WCNYIPA.com. Please check that out. And I think that the acknowledgement of the role that we have as organizations, as well as communities, as well as individuals in these systems is something that we want to emphasize. All right, so let me go back to the slideshow here. I hope this is going well for all of you in this process. I'm going to just try to go from the, oh, I went to the wrong one. Here, let's go back here. So here's the thing about the interdisciplinary models. There's a lot of qualities for interdisciplinary models, but there's a few that I want to just lift up and focus on. One is whether this is as a staff person or as a member of the peer-run organization, having a collaborative approach that was viewed, like Jonathan said, where your supervisor said, look, you're a discipline. You get your, what that person was saying, my understanding of what that meant was that you're equal to the others in the room here. Right? Don't see your point of view, even if it's different, as less than somebody who's a psychiatrist or somebody who's a nurse or somebody who's a social worker or somebody who's an employment specialist or whatever the discipline was on the team. What we were trying to do is emphasize the actual value of the diversity in that interdisciplinary team. So the interdisciplinary team wasn't just following one discipline's framework, but was working in a very complex manner to hear multiple worldviews. And it's best when done at a team meeting. At OnTrack, we do it every week. All right. So weekly, it's part of our fidelity model to have teams meeting weekly to actually hear from each other about the people they're serving from an interdisciplinary perspective. So the question for us, if we're offering peer support, is, are we feeling like we are heard at that level or expressing ourselves at that level of equity in the team? Inclusion at that level means that we're also valuing each other's intersectionality, that everyone's coming not just with one identity, but with multiple social identities that have multiple and varying levels of power, privilege, marginalization, oppression. We're people of color in the room, we're men, we're trans, we're women, we're a number of different identities, from criminal justice involvement to hospital involvement to different systems involvement. There's experiences of life that really need to be honored in those team interdisciplinary conversations. Shared decision-making is a model where decision-making happens together. There's some team talk, they call it. So how does that team talk occur with peer support? And that's really important to be thinking about. Integrated care is this, when we were talking about integrated care, a lot of my interaction with many of the clinics was really bringing addiction, mental health, and physical health concerns together. And how do we really hear and understand those needs together? Interdisciplinary models really recognize peer roles, as I said, as critical in care, in the care process, but also are compensated accordingly. And a lot of the human resource basics, whether it's having a job description or good supervision and support and opportunities to really learn and grow as a field, as a discipline, includes growing from a compensation perspective and valuing the role from a compensation perspective. So when you're developing your budgets and you're seeing, oh, I can get away with a strong peer support model because it's inexpensive, I would like you to rethink that. It may not be as inexpensive as you think initially if you're going to implement it properly, but it will save you money. And I think that's the part that we're trying to say, that where the savings actually isn't in the cost going in, the savings is in how much people aren't reusing the system in crisis and emergencies and in hospitals. And, the same people that were in and out of hospitals out of a Peer Bridger project, for example, before working with Peer Bridgers, were no longer going back again, at an incredible rate, 70%, after our evaluation. So I think, you'll find that, and we're seeing that over and over again, whether it's jail diversion and other kinds of costs as well. So making the case for peer support is about making the case in a way that says, here are the outcomes we're able to reach as a result. Jonathan, before I move on, anything else you wanted to say about the qualities of interdisciplinary teams as you were implementing them at the hospital?
Not exactly. What I wanted to do was to just sort of expound on what you were just saying about the savings and sort of leveraging that point and that belief that we shouldn't be looking to sort of squeeze the budget going in, but really glean the benefits of what happens when the care system is better and people are happier and people are healthier. And, one of the things I wanted to say is that philosophically, I think if you do the right thing for the right reason and you're not looking at, cost savings, for example, and you're looking at really helping people and helping people to feel empowered and helping people to be healthier, that, the financial piece is secondary gain. But it's easy for me to say that because I'm not running a hospital and I'm not responsible for showing that we've decreased our budget. And unfortunately, a lot of how peer supporters are implemented into systems is very financially driven, regardless of what people will tell you. And it's always I call it the nickeling and diming. And I have to be very careful when I'm at the table because I want to stay at the table. So I have to find a way to say these things that are impactful but not insulting, if that makes sense, because it can bring up a lot of feelings, because I know many of my fellow peers are grossly underpaid and may even work a second job in order to achieve a decent standard of living, and that's not necessarily healthy either. That should be what one does voluntarily rather than has to do to make ends meet. So there's all kinds of social justice issues that are embedded in implementing peer support, both in the culture and as well as how people are living. So, really,
well, and I think that's exactly right, Jonathan. I mean, we don't want to trade the incredible intellectual labor that you offer and the direct labor that you offer as peer support for a cost savings kind of dynamic alone. But I do want to emphasize that is one of the drivers that have made peer support so prolific in this 21st century. So the financial outcome of because they're kind of a triple aim. There was kind of improving outcomes, right? It was a really key factor. And you need to know this if you're involved in peer support. Improving the quality of our services and support and for what people got, all right, was directly related to outcomes, but also decreasing cost. Because those of us with co-occurring mental health, substance use, and physical health issues were spending probably we were only 20% of the Medicaid population, for example, yet the cost was 80 sometimes percent more of that Medicaid expenditure. So there was a runaway cost as everybody's concerned. And then when we started to see that peer support could offer some solutions to that, that's great. I think that's a wonderful win. And, so I'm not arguing with that as much until it gets exploited. And it got exploited kind of quick. All right, so what we need to be able to do is recognize that. I see somebody's drawing on the slides. I'm not sure if that's if that's intentional, but if you do, give me a nice mustache and beard. You know, that's the way to go when my picture's up.
Well, my hands are folded. It's not me.
That's okay. Yeah, so let's use the emergency rooms as an example. I mean, so the picture you see in front of you here on the slide is of the core Penn team in University of Penn, and this was one of the emergency room implementation models of peer support. We saw it first in Rhode Island implemented directly. I was at a press conference with the governor of Rhode Island when they first wanted to reduce overdoses that were happening in Rhode Island and overdose rate there. And Jimmy Gillian and I and some of the recovery advocates in Providence, Rhode Island, stood by with the governor, who announced he wanted recovery, peer support and recovery in every emergency room in Rhode Island, and that's what happened. You know, and they started to really make that change. You started to see these kinds of models really reduce not only the negative experiences that people were having in emergency rooms, which we certainly experienced in New York and had many problematic issues, people dying in emergency rooms, tragically being ignored in the emergency rooms with overcrowding, but more importantly, even not having to go in anymore because they were aware of resources that were in the community or connected to resources as a result. So not only were we saving lives and keeping people from dying while they're coming into care in an emergency room, but preventing the need to even show up there in the first place because now they were connected to healthcare coverage. Maybe they didn't know they had coverage before. Maybe they didn't know that there was a resource like a warm line or a peer support or a crisis respite that was right down the street that they could turn to. And many of you have made those solutions possible. So we are so grateful to you for doing that. And so now we're asking, how is it possible to go into the system, hold our voice? And I'm going to use a brief analogy and turn it over to Jonathan for this last point. And this is from Khalil Gibran. How do you create a house where you don't have to fold your wings to walk in the door? That's what we want to do.
Yeah, I'd like to make a comment if I can.
Yeah. Just let me finish this thought, and
Sure.
then I'll offer that. That's great. I don't know who that was for the moment, but
That was William. Yeah.
Okay, thanks. Okay, William. How do you create where you don't have to bow your head because the ceilings are too low? How do you make sure you can breathe fully? Full breaths and let the walls crack, you know? So that's it. Go ahead, William.
Yeah, one of the things that often, I'm not sure if the word bothers me, it concerns me sometimes, is when I attend certain presentations like this one. And believe me, first of all, I'm a CRPA myself. I'm a trainer. I work in the Bronx, et cetera, et cetera, et cetera. So, but one of the things that concerns me is sometimes, and I'm gonna say it's happening here, but sometimes people can walk away with this us against them mentality, all right? And that can happen when we continually praise one side and we don't do it to the other side, so to speak. And again, I'm not saying that's what's happening here.
Yeah, no, I appreciate it.
A point that was brought up before was about how peers are underpaid, and that's absolutely true, all right? CASACs are also underpaid, right? I know peers that are making more than CASACs, right? So we've got a problem with the system, with the behavioral health system in general when it comes to that type of thing. You have people, CASACs as well as peers, who are getting caseloads that are beyond what they should be having. Okay. The other thing, a lot of what was on that previous slide before, and that's the interdisciplinary work, the behavioral team and an individual provider organization's treatment program, for example, is absolutely important. And that's where I think the supervision comes in. All right. The supervisor has a great challenge and a great responsibility to be the advocate for the peer services in that particular organization. A lot of what's going on, I'd like to think, is not necessarily a bias, so to speak, but just an unawareness of what's going on. In the same way that the system that we work in now uses the word denial, resistant, non-compliant for people who come in for services, maybe that's not what's happening. Maybe it's just a person who's in pre-contemplation is unaware. So I'd like to think of it in the same way with the system that I work in and a provider, for example. If I've got pushback from the administrator or pushback from clinicians, a lot of it is based on their ignorance. They're unaware of the role that a CRPA plays, all the good stuff that you mentioned before. I mean, all of us here who are CRPA, we know how valuable we are, right? The next step is for us to teach up, as Terry used to say it for New York. We need to teach up. It's not us against them. We need to help them along and make them more aware of what we do and how we help. Yeah, so I'll just stop there.
Well, that's great. We're very well said, William. Thank you for taking the time to express all of that. And I think that's all true. We want to emphasize it. And so, and I am going to, overemphasize, however, in this context, the value of peer support and helping. It's not intended to be an us and them message. If nothing else, the interdisciplinary idea is just that equity across all roles is something to be thinking about. And how does that actually get accomplished in a system that, frankly, is dependent on our bodies as a commodity? So you're participating in that unless you address it. And so we're very challenged by these realities. But at the same time, able to recognize the humanity of every single person that's involved in the process with us. Whether it's people who haven't heard about peer support and don't understand it and need to be taught up or managed up or educated about it, as well as people who are opposed, to the presence of us because of bias or because of attitudes that are needing to be changed. So I think the leadership that you offer, this is an opportunity in an era for that leadership to be embraced both by others, but also by ourselves. And as the president of Friends of Recovery New York, William, for example, and the founder of the organization, for example, and our efforts was part of that, was about really claiming that authority and leading with that authority of our experience, unapologetically, but at the same time, recognizing that liberation comes for all of us, not just for one group or another, but all boats will rise if we go there, and that's the hope. All right, now let me, I was ending on that last line. So Jonathan, let me turn it back over to you. And should I bring up the slides for you first, or did you want to say anything before we go?
Just quickly, I want to thank William for making the point. I always call this a delicate dance, and a dance that even Fred and Ginger could not have mastered, because it's very easy to bash the other side or to sound unsympathetic. And you're exactly right. The behavioral health workforce, there's a crisis across the board. We have a major crisis in New York City of the state of the behavioral health workforce, and the difficulty of bringing people on and retaining them. Yeah, and you're right. I think CASACs and social workers, I'm licensed as a social worker. I don't work in a social worker line, but I know that, there was a lot of advocacy in the social work profession some years ago, and that's why the salaries have increased somewhat. But I think most human service workers are underpaid. And I think sometimes to talk about peer support in the context of those other disciplines, it's really important. There is one thing, however, is that peer supporters are working at the intersection of not just being undercompensated monetarily, but also stigmatized because they're practicing openly through a lens of lived experience. So sometimes the inequity of criticism that we have is driven, and just like mine was a few minutes ago when I was saying that people are underpaid and they have to work second jobs. And I know some RNs who work 2 jobs. you know, and I'm not going to make a judgment about that, but I think working as a peer support worker or a CRPA, you're dealing with the injustices that are already in the system, plus the other injustices that might go across the board. So
Yeah, I
the
like the way you put that.
intersectionality
Yeah.
piece is really, really important. But I do appreciate what you're saying, because being at the table, it's a delicate dance. And you know, we just like we model by meeting people where they are. And we
There you
want
go.
clinicians
There
to
you
do
go.
that with us. That, you know, I used to work with my supervisees a lot in terms of like shock the system, meet them where they are. It doesn't mean you got to stay there.
Exactly.
But meet them where they are in terms of like hearing them, and then, you know, that can better inform your debate.
Jonathan, let me just add one more point around
Yeah,
the case
sure.
acts, because William brought up case acts, for example. So, you know, the history of the case acts, you know, are that, you know, a lot of people were actually people in recovery first, and
Yeah.
you know, started the credential, right? So the credential was before it was case act, it was an alcohol, you know, counselor role. And 80% of case acts were disclosing openly about being people in recovery.
Yep.
You know, in the early days, and then up until about 2000, when the money started to flow and started to hire up more case acts, and the credential became even more professionalized in the 90s and up to 2000, that
Right.
number of disclosure, the number of people disclosing, went down to 20%.
Yeah.
And there were actual policies telling people not to disclose, which exists today, to this very day, in many of the systems. So the attitudes behind those policies were many, but I think I just want to kind of emphasize some of the losses and the lessons learned that some of the same advocates that were, you know, working towards the CRPA, for example, as you said, William, you are, wanted to make sure they didn't make the same mistakes again, you know, around, you know, forgetting about how to ensure the peer values that were driven originally by the, you know, into the case act, and then now are intended to be really followed from a CRPA perspective and peer support perspective. All right, Jonathan, back to you. Sorry.
Yeah, sure. And Kestrel just put into the chat that my facility does not allow case acts to disclose. So that's tremendously disempowering. I think we're in the age where, at least from talking with a lot of people, and I've been in the workforce for a long time, is that there are people who want to disclose and don't have any experience doing that. There are other people who they may disclose somewhat through how they listen, through how they identify, but the explicit disclosure that peer supporters and recovery coaches and CRPAs practice, it's unparalleled. You know, we should get back.
That's one of the trends, yeah. But I think that is one of the transformative kind of functions of peer support, John, is making it okay to be who we are at work.
Yeah, absolutely.
I mean, for whatever discipline you are, whether you're a psychiatrist with lived experience, you know, of whatever sort, or of any kind of marginalized identity, similar to the pay issue, we want everyone to feel like they can be who they are at work. And if we're helpful in making that possible, as opposed to keeping a part of yourself silent or hidden, you know, that would be much more powerful. Anyway, all right, go ahead.
Yeah, where, you know, I one of the other things I would, you know, say to people I supervised was, you know, you are a change agent, you know, and yes, that's important, that it's not just for the benefit of the peer support worker, but the benefit of the culture, and really modeling the courage for other individuals. So in a lot of ways, the peer supporter is in that role of teacher. Okay. So yes, let's jump back into the slides. It's getting really lively. Okay, so you're probably all wondering why you're seeing the peacock again. It's not a mistake. It's not just that the peacock is really beautiful, but we're at the point where you know, we're sort of circling back and expounding on some of the points that were made earlier, and also reiterating some really important ones. So we've been leading up to, you know, peer services and how it not only is value add in terms of service, but also promotes social justice and system transformation. And so when we look at peer services as innovative disruption, the first thing that comes to mind for me is Pat Deegan, who many of you probably know. And Pat Deegan is a white woman who is identifies as a mental health consumer. She identifies she's a licensed psychologist, I believe. She was told at one time by her doctors, and she keynotes about this around the world, that she was told by her doctors to find some good television programs and to go home and, smoke cigarettes and relax. And she talks a lot about going into the system and having the privilege, as a white person with a licensed degree, and being handed the keys to the ward, and just really learning to use her privilege for good and doing the dance around not becoming co-opted, but making change within systems. So she's coined this a saying, or at least popularized the saying, disruptive innovator, as one of the roles that peer supporters embody, that just the mere presence, and I think I've heard Chacku say this, just our mere presence in the system is a disruption, because we're going against a lot of belief systems. For clinicians and other staff who have seen us in states that may have not been so favorable, they didn't get to see us when we went back to work, and when we began to use our own lived experience to support others and to change the culture. So just the mere presence of people who are practicing openly through the lens of lived experience is a disruption. Advocating for individuals who may not be able to advocate for themselves, or modeling for individuals how to advocate for themselves, that's disruption, because the system is set up in a very paternalistic and hierarchical nature, where at one point people using services were called recipients. So it was set up as, I'm receiving what you give, as opposed to like a partnership or a shared decision-making model. We also talked about peer support not simply being an additive to service to the existing system. And Chacku talked a lot about the social justice role that peer support plays, and also centering the lived experience at every level. So yes, it really should be okay for anyone, whether you work as a peer supporter or not, to be yourself, and hence our beautiful peacock again, because the change is really, our goal for change is system-wide, not just among peer supporters. Racial equity and inclusion, which I think can sometimes be eclipsed or erased or not even thought of, because we're looking at the issue of injustice as one-dimensional, peer, non-peer, us and them, well on well. And sometimes, and I've seen this happen in the peer supporter movement, is that issues around racial equity and inclusion don't get talked about. It still happens, and so just as some of the peer supporters are at that intersection of being undercompensated and stigmatized, many of us are also dealing with racial inequities, the stigma of having, been given a diagnosis, undercompensation. And so racial equity and inclusion are factors that we really need to bring into the conversation and to talk about, because in a lot of ways, the peer support movement at various stages has overlooked or not talked about those issues. And I know my colleague here, Chacku, can talk very passionately about that. And then harm reduction, and we talked a lot about harm reduction when we met with some of you 2 weeks ago. And we're used to hearing a lot about harm reduction in substance use, but in terms of really talking about it in mental health, before we were talking about people, who hear voices. And I think the reaction is always, we have to get people to stop hearing their voices. We have to get people to stop, injuring themselves. We have to stop, people from expressing their unhappiness about their lives, and really learning to once again meet people where they are, to understand that there are certain things that people do to comfort themselves and to cope, and to not pathologize or eradicate some of the things that people do in order to to continue to be here, to be present. And as you know, in substance use, just the use of MAT alone is a good example of harm reduction, rather than trying to tell someone or make someone to stop using drugs, to help someone to wean themselves off and to also reduce the risk for people who are still using substances, because safety and health promotion are still really important. And just because a person might be using drugs or hearing voices, it doesn't mean that they're not entitled to the same level of care as someone else. So harm reduction too is a big piece around social justice that we really need to talk about more. So this is a part that I'm really excited about. And I'm looking at the time, we're at 2:12, and we want to make sure that we get through this and hear again from you. I think, William, you brought up supervision before, and we're moving into that now. But first, we want to talk a little bit about some of the core values of peer support. So these core values were sort of developed by the National Association of Peer Supporters. The most recent publication are National Practice Guidelines for Peer Specialists and Supervisors, which was published in 2019. Very happily, I was a part of helping to develop these and flesh them out from their original state, which I think was in 2013. And that effort was led largely by one of our other colleagues, Rita Cronice, who I believe was able to enlist feedback from probably nearly 1,000 peer supporters with 98% agreement on these core values. So some of them are not going to be any surprise. Hope is really important. Being open-minded, being empathic, respect is sort of at the foundation of everything we do. Being honest, direct, and clear. Peer support should always be voluntary. In other words, peer support should not be a mandated service in a hospital or in a clinic, but it's something that people should be able to choose. Peer support is mutual and reciprocal, which means that it's not one way. You're not just telling me your problems without my being able to model for you how I might have dealt with something in particular. But that's not the same as telling you how to do it or giving you advice, but it is the role modeling. Equally shared power, moving away from the hierarchy, strengths focused, transparent, and person-driven. We're going to talk a little bit about how these get operationalized. Next slide. What we have here are supervision principles. So this is a model that actually happened by accident. And what I mean by that is the same supervisor I told you about who said, you're going to work in a hospital now, you're a discipline director. She sat me down one day and she said, have you taken stock of all the things that you've done supervising individuals who are on a speaker panel, supervising volunteer workers? And she had me sort of put together an inventory of what I did, and I ended up making this chart, this matrix, 5 critical functions of supervisors, not knowing that at some point I was going to be working with Rutgers University on validating competencies to support this model. So it's a strength-based model of supervision that organizes supervisory tasks and serves as an accountability tool, because I also needed to better understand what I was doing, not just what I was guiding other people in doing. It expands on SAMHSA's 3-function model, which is administrative, educative, and supportive. And we built this out, and I say we because now I'm working with other people on further developing the model. We built it out to include an advocacy and an evaluative function. And lastly, it accounts for nuances of addressing peer specialist concerns without creating a double standard. So what we have found and experienced is that many peer supporters are coming back to work after long periods of hiatus. I like to liken that to someone coming back to the workforce after raising a family, which is more than a full-time job, but you're coming back into the workforce setting. Or someone who might have been out for a long period of time because they had an accident that limited their physical capacity. So similarly, people are coming back into a system where things have changed, technology has changed, policies and procedures have changed. It's really, really important to understand that as a supervisor and to work to support the individual to thrive in the setting without creating a double standard. So this particular model does account for some of those nuances, and I can talk about some of those momentarily. Next slide. So this is a visual of the 5 critical functions of supervision, and these usually are operationalized in tandem. They're not, usually when you're doing administrative tasks as a supervisor, you may also be advocating, because that administrative task might be to sort of write up and justify why you think your staff should be making a higher salary. Support and advocate oftentimes are operationalized simultaneously. But let's go to the next slide. So this is 5 critical functions of supervision in practice, and this is sort of the original conceptualization of this 5-function model. And here are some of the examples of each of the functions that we talk about and that we find to be very common in the practice of supervision. Just to go through this very quickly, looking at the administrative column, I always contend that supervision doesn't begin with people sitting at opposite sides of the desk, but during an interview, hiring, recruiting individuals, assessing the potential fit of the relationship, orienting staff to organizational structure during onboarding, helping staff to understand practices, policies, and procedures. If we jump over to support, a lot of that has to do with building rapport by providing constructive feedback, inspiring excellence, and promoting wellness and self-care for all employees. Utilizing a strengths-based and trauma-informed approach to help staff problem solve. And then I'll jump over to advocate, because that was one of the ones that we added. Fostering good morale and a respectful work environment, strengthening the practice of peer support by promoting its value, negotiating reasonable work accommodations when appropriate. Now, who here could tell me that this could not be used to supervise anyone? And that's what I mean by creating an accountability tool that accounts for some of the nuances, but doesn't create a double standard. But these were developed from a supervisor who was working with peer supporters and saying, what do I need to do as a good supervisor to help people to succeed and to thrive in the setting? But then a retrospective look made us see that you can use this to supervise anyone. And that these are not the only competency or competency statements that support these functions. These are examples. So this is something that we oftentimes use in our presentations around supervision. We use this to inform role plays and really to have participants to select some of these competencies to really say how that they would address a particular situation that comes up in supervision. So we should go to the next slide. So key principles for supervisors, these play off of the core values that we talked about several slides ago. And so I'll go to the second bullet here. Supervisors demonstrate confidence in peer specialist ability to share a hopeful message. Supervisors practice effective listening that is non-judgmental and empathic while balancing the need to hold peer support specialists accountable for their job duties. Let's go to the next slide. Here are more key principles for supervisors. Supervisors establish clear boundaries, set reasonable and mutually agreed on expectations. I always talk about supervision in the sense of being a partnership, that the communication is two-way. Supervisors encourage co-learning, collaborative learning, and welcome peer support specialist input in decision-making wherever possible. Let's go to the next slide. I'm not reading all of these deliberately for the time's sake, but you'll get the materials next Thursday, I believe, and you'll have all the slides. Supervisors model a focus on strengths rather than deficits with all employees. And lastly, supervisors provide an environment where peer support specialists are empowered to move beyond comfort zones and learn from their mistakes. Let's go to the next slide. So here is something that I wanted to add to this presentation, because it's really looking at the core value, the practice, and the supervisor's role in supporting the peer support specialist in doing this work with respect to this particular core value. So we're operationalizing the core values of peer support. And this document, which we'll also make sure that you get, does this for all 12 of the core values. So this one in particular was, we wanted to use as our model, peer supporters facilitate change. So it all begins with looking at some of the worst human rights violations are experienced by people with psychiatric trauma or substance use challenges. These individuals, including myself, are or were frequently seen as objects of treatment rather than human beings with the same fundamental rights to life, liberty, and the pursuit of happiness as everyone else. So an informed peer specialist working in the system, knowing this, their role is going to be to educate and to advocate. Some of the ways that happens is that peer supporters recognize and find appropriate ways to call attention to injustices. And that likens to that whole concept of being a disruptive innovator. Peer supporters strive to understand how injustices may affect people. And peer supporters encourage, coach, and inspire those they support to challenge and overcome injustices. So really helping someone to learn the art of self-advocacy. The supervisor's role in supporting this process looks as follows: defining and modeling advocacy for peer support specialists, including advocating for organizational changes. So there's a parallel process there. The supervisor is actually modeling how pushback to the system to advocate for more just conditions looks like. And it's very, very difficult work. I mean, it's here on a chart and a table, but it's not easy work. But that's why it's really important to show how the core value is operationalized by the supervisor. Secondly, to coach peer support specialists on how to respect the rights of individuals while helping them to challenge and overcome injustice. And lastly, to build on lived experience, model recovery, and advocate for peer support workers. So everyone has a share in this, and there are things that the supervisor can do, and we're hoping that this knowledge and that this table that we provide, along with the other principles, can help to do that. Let's go to the next slide. So I think we're back to Chacku to talk about educational models and peer support.
Yeah, and I'm not going to spend too much time here, but I do want to make sure we're letting you know that a lot of the models that have been emerging, if you didn't know about it, there are a couple of major associations to be knowledgeable about and go check out. One is the Association of Recovery in Higher Education, and the other is the Association of Recovery Schools. So as I was mentioning, I came into this process pretty young, and one of the things that happened was that my father was talking to somebody at his church, and he's saying, yeah, my son's in the hospital, he just tried to kill himself, he's on drugs, he's in the street, and, I can't do anything, he doesn't trust us, he doesn't, I don't know what to do. And so when he was talking to this man says, me too. 2 words, most important things that my father ever heard at that time. And he said, my son, and that man said his son was also going through a similar thing. And he had just taken a medical leave from Xerox at the time and was working with some families to renovate an old horse barn across from a high school. And they were planning on giving it to the young people who were coming out of treatment programs or needing a safe place to have as their own recovery center. And they called it Students of Brighton Encourage Recovery. It was an old barn. He said, maybe your son will go there. And my dad was like, I don't know. He doesn't trust anybody. There's always a fight wherever he goes, And so he as I got out, he brought me over there, and I looked through the window and I saw the same old kids that I was getting in fights with in the past. But I opened the door anyway, and some kids turned to me and said, hey, you want to play pool? And something about the way this person who didn't look like me, talk like me, act like me, sound like me, or anything, I was a lot different than him, said the way he said what he said, and it was very inviting and warm. It just kind of dropped my guard. I hadn't dropped my guard in 10 years prior to that. I was so guarded. And but it made me walk over, grab a pool cue and say, yeah, I'd like to. And I became a member of that community. I was an advocate in that community. It kind of was my start as an advocate. And that was as a teenager in high school, right? And that was my introduction to a peer support community. That's the kind of thing. And now we have, multiple, youth clubhouses around New York State based on that model, for example, but we have models like that in high school too. So the other thing we did that community did is that we changed how things were done in that high school and other high schools in the city to actually accommodate people who are going through the recovery process. So we had self-help meetings in school, we had separate homerooms, we had special counselors, we had, you know what I mean? We had a number of models that were going on in a mainstream school. And then you had kind of different models happening like that in collegiate recovery. So Rutgers was one of the few earlier ones, and there was some in Texas and a few different places in the collegiate recovery space that started making it possible for people to say, you know what, I'm going to be in recovery and go to school, because it was kind of a decision. Like, so I struggled. I by the time, you know, the Americans with Disabilities Act had not even been passed yet by the time I was considering these kinds of things, and I really just self-selected my way out of it and said, yeah, there's no way I'm going to make it through these situations alive. And try to go to school at the same time. But now, not only are people making it through college alive, but they're making it through college like Dr. Jonathan Edwards with doctorates and other programs, having been supported by incredible recovery support models, whether it was in their residential model of kind of a residence hall that was a safe space, or now they're incorporating harm reduction into those spaces. So it's not just about being abstinent on the ward on that particular residential unit, but it's about a model of support for each other. And the same is true for recovery schools. Florida Inclusion Network is a peer support model supporting students with mental health challenges. So there's a lot of different models that are happening out there now. And I think it's exciting to see, because I don't know about you, but any college I approached to try to address their suicide rate, overdose rate, addiction rate, wanted to deny. They didn't want to even look at the data until it was too late, until there was a tragedy in the news. And then they were coming to us saying, what can we do? So now we don't have to wait. We have enough data to show people what's possible. So let me stop there. John, in the interest of time, I know we want to open up some conversations about all of this, but I will, you know, before one last slide is that, you know, I was asked to organize this National Youth Summit focusing on advancing peer support and other kinds of models for young people across the country. And what you see here, you know, just, we brought together a couple hundred young people to guide SAMHSA's plan at the time. And this was, you know, only, 10 years ago or so, maybe. But I think the advancing of that model, and now we have an Office of Recovery at SAMHSA that's really interested in not only advancing education, but also in adapting evidence-based practice around individual placement and support for employment, for example, to be more effective for young people going to school. So that's another example there to be considering. All right, so takeaways, Jonathan, we want to talk about that?
Yes. So just as we started out by asking you about expectations, of which I hope we met some, now we sort of want to hear from you what you're taking away from this conversation, and some of the things that you can go back to your place of work or other settings and feel like you can make actionable. And I know that those were some of the expectations, that you get new tools and build your skills and listen, and sort of feel like you're walking away with something. So we really want to hear about that now. And you could put it in the chat, or you can unmute yourself. And I'm going to go to the chat and see.
I'm taking away that that I can be a peer advocate support with confidence, that I can bring myself to the table and not be ashamed of my past, but could be open.
That's really good to hear. David or Dave?
David.
Great, because I have a feeling we're going to be seeing you again, so I want to get your name right. Well, I want to get your name right anyway, but thank you.
Oh, well, what, man, what Mr. Mathai,
Yep.
Mathai, thank you.
You can just say Chacku, though. You don't have to.
Okay.
I
It's
already
an
told him
old-
that about Jonathan. I said, call me Jonathan.
yeah. See, it's an old military habit. I mean, no disrespect, I promise.
No.
No problem, sir. You got it.
And it well, it gave me more confidence in doing my job overall. And to not and to give advice as kind of like a friend, not as a provider, if that makes any sort of sense. And and Chaku, and you just reinforced something that I've always kind of known. When you spoke about schools ignoring data until things happened. Um, Humans are very good at adapting, not preventing. And whenever I see whenever I see or hear things like that, I try not to get discouraged because for some reason, call it the human condition. We don't like to acknowledge something until it's literally until it's literally in our face. But that's in part like why we're here, and to try to stop that from happening. So.
Yeah, thank you for saying that, Larry. I think, like William was offering, you're offering some wisdom about how we can engage our leadership in these settings where people are struggling to really make changes, right? Or find solutions. And a lot of times part of the reason why they've been struggling is because of the absence of people like yourself and all the expertise in this room, right? So when that wisdom gets to show up in the room, there's a chance for some new information to be offered, right? Why hold that back? Because this is the opportunity we have to learn from each other. So thank you so much for sharing that.
Thank you again, Lawrence. And then, in closing, and as they say, I'm so sad this time has come, or however the song went. I'm glad we had the time together. Actually, I'm not sad. We had some other takeaways, and they're important to hear about what you were taking away, so that we know that we showed up in a way that was meaningful to you. If we could put the slide up with the barcode on it, as we're doing that, we want to let you know there are also robust references in these slides that I think you'll find interesting. There's other information in here. What's really most important is that we get your feedback. So if you can scan this and complete these, we'd really appreciate it. And there's a direct link also from Katie in the chat. Thank you, Katie.
Thank you.
Thank you all so much, everyone in attendance, for your engagement and interest in this, and especially to both Chacku and Jonathan. It's so incredibly inspiring and helpful to not only hear about the work that you've done, but to have these tangible tools to point to when talking to other people about the work, but also advocating, on behalf of peer specialists, on behalf of clients, etc. And as they've shared, we'll be sending all of the slides, the recording of today, as well as related resources and materials to you all. I'll also be compiling throughout these a list of organizations that have attended, as well as the titles of the names and titles of the people from those organizations, so that hopefully continue the conversations. Speaking of which, you'll see in the information that I pasted that there's a free forum that we have for continuing the conversations, where you can go and post about either a service that you're offering or a project that you're working on, or some supports that's needed, etc. cetera. And it really helps with, continuing and taking the information that we learned today and really turning it into something that makes an impact. So thank you all. I'm going to leave this up for a couple of minutes. You have my information if you want to reach out direct. Otherwise, I hope you all have a wonderful rest of the week and a restful weekend.